Adenoids and other inflammations of nasopharynx. Anatomy and physiology. Adenoids. The nasopharyngeal tonsil, commonly called adenoids, is situated at the junction of the roof and posterior wall of the nasopharynx. It is composed of vertical ridges of lymphoid tissue separated by deep clefts. Figure 48.1. Adenoid mass after removal with curette. Note the ridges of the lymphoid tissue separated by deep clefts. Covering epithelium is of three types: ciliated, pseudostratified columnar, stratified squamous, and transitional. Unlike palatine tonsils, adenoids have no crypts and no capsule. Adenoid tissue is present at birth. It shows physiological enlargement up to the age of 6 years and then tends to atrophy at puberty and almost completely disappears by the age of 20. Blood supply. Adenoids receive their blood supply from ascending palatine branch of facial, ascending pharyngeal branch of external carotid, pharyngeal branch of third part of maxillary artery, ascending cervical branch of inferior thyroid artery of thyrocervical trunk. Lymphatics from the adenoid drain into upper jugular nodes directly or indirectly via retropharyngeal and parapharyngeal nodes. Nerve supply is through cranial nerve 9 and 10. They carry sensation. Referred pain to ear due to adenoiditis is also mediated through them. Etiology. Adenoids are subject to physiological enlargement in childhood. Certain children have the tendency to generalized lymphoid hyperplasia, in which adenoids also take part. Recurrent attacks of rhinitis, sinusitis, or chronic tonsillitis may cause chronic adenoid infection and hyperplasia. Allergy of the upper respiratory tract may also contribute to the enlargement of adenoids. Clinical features. Symptoms and signs depend not merely on the absolute size of the adenoid mass but are relative to the available space in the nasopharynx. Enlarged and infected adenoids may cause nasal, oral, or general symptoms. Nasal symptoms. Nasal obstruction is the commonest symptom. This leads to mouth breathing. Nasal obstruction also interferes with feeding or suckling in a child. As respiration and feeding cannot take place simultaneously, a child with adenoid enlargement fails to thrive. Nasal discharge. It is partly due to choanal obstruction, as the normal nasal secretions cannot drain into the nasopharynx, and partly due to the associated chronic rhinitis. The child often has a wet, bubbly nose. Sinusitis. Chronic maxillary sinusitis is commonly associated with adenoids. It is due to persistence of nasal discharge and infection. Reverse is also true that a primary maxillary sinusitis may lead to infected and enlarged adenoids. Epistaxis. When adenoids are acutely inflamed, epistaxis can occur with nose blowing. Voice change. Voice is toneless and loses nasal quality due to the nasal obstruction. Oral symptoms. Tubular obstruction. Tubal obstruction. Adenoid mass blocks the eustachian tube, leading to retracted tympanic membrane and conductive hearing loss. Recurrent attacks of acute otitis media may occur due to the spread of infection via the eustachian tube. Chronic suppurative otitis media may fail to resolve in the presence of infected adenoids. Otitis media with effusion. Adenoids form an important cause of otitis media with effusion in children. The waxing and waning size of adenoids cause intermittent eustachian tube obstruction with fluctuating hearing loss. Impedance audiometry helps to identify the condition. General symptoms. Adenoid phases. Chronic nasal obstruction and mouth breathing lead to characteristic facial appearance called adenoid facies. The child has an elongated face with a dull expression. The child has an elongated face with a dull expression, open mouth, prominent and crowded upper teeth, and hitched up upper lip. Nose gives a pinched in appearance due to disuse atrophy of alae nasi. Figure 48.2. Adenoid facies. Patient is a mouth breather. Pulmonary hypertension. Long-standing nasal obstruction due to adenoid hypertrophy can cause pulmonary hypertension and cor pulmonale. Aproxexia. Aproxexia is lack of concentration. Diagnosis. Examination of the postnasal space is possible in some young children, and an adenoid mass can be seen with a mirror. A rigid or a flexible nasopharyngoscope is also useful to see the details of the nasopharynx in a cooperative child. Soft tissue lateral radiograph of the nasopharynx will reveal the size of the adenoids and also the extent to which the nasopharyngeal airspace has been compromised. Figure 48.3. Enlarged adenoids arrows in a 7-year-old girl. There is very little breathing space in the nasopharynx. Detailed nasal examination should always be conducted to exclude other causes of nasal obstruction. Treatment. When symptoms are not marked, breathing exercises, decongestant nasal drops, and antihistaminics for any coexistent nasal allergy can cure the condition without resort to surgery. When symptoms are marked, adenoidectomy is done. Indications and details of the operations are discussed in the section in operative surgery. Acute nasopharyngitis. Etiology. Acute infection of the nasopharynx may be an isolated infection confined to this part only or be a part of generalized upper airway infection. It may be caused by viruses, common cold, influenza, parainfluenza, rhino or adenovirus, or bacteria, especially streptococcus, pneumococcus or haemophilus influenzae. Clinical features. Dryness and burning of the throat above the soft palate is usually the first symptom, as is commonly noted in common cold. This is followed by pain and discomfort localized to the back of the nose with difficulty on swallowing. In severe infections, there is pyrexia and enlarged cervical lymph nodes. Examination of nasopharynx reveals congested and swollen mucosa often covered with whitish exudate. Treatment. Mild cases clear up spontaneously. Some analgesic may be required for relief of pain and discomfort. In severe cases with general symptoms, systemic antibiotic or chemotherapy may be necessary. In children, there is associated adenoiditis, which causes nasal obstruction and requires nasal decongestant drops. Chronic nasopharyngitis. Etiology. It is often associated with chronic infections of nose, paranasal sinuses, and pharynx. It is commonly seen in heavy smokers, drinkers, and those exposed to dust and fumes. Clinical features. Postnasal discharge and crusting with irritation at the back of the nose is the most common complaint. Patient has a constant desire to clear the throat by hawking or inspiratory snorting, forcefully drawing the nasal secretions back into the throat. Examination of the nasopharynx reveals congested mucosa and mucopus or dry crusts. In children, adenoids are often enlarged and infected, chronic adenoiditis. Treatment. Chronic infections of the nose, paranasal sinuses, and oropharynx should be attended to. Excessive smoking and drinking should be corrected. Preventive measures should be taken to avoid dust and fumes. Alkaline nasal douche helps to remove crusts and mucopus. Steam inhalations are soothing. Thornwald's disease or pharyngeal bursitis. It is infection of the pharyngeal bursa, which is a median recess representing the attachment of notochord to the endoderm of the primitive pharynx. Pharyngeal bursa is located in the midline of the posterior wall of the nasopharynx in the adenoid mass. Clinical features: persistent postnasal discharge with crusting in the nasopharynx. Nasal obstruction due to swelling in the nasopharynx. Obstruction to the Eustachian tube and serous otitis media. Dull type of occipital headache. Recurrent sore throat and low grade fever. Examination would reveal a cystic and fluctuant swelling in the posterior wall of the nasopharynx. It may also show crusts in the nasopharynx due to dried up discharge. Treatment: antibiotics are given to treat the infection and marsupialization of the cystic swelling and adequate removal of its lining membrane.